but we can do. So I'm going to turn it over to you. Thanks so much for being here.
Thank you, Sarah. Really great to see you as well. And thank you to the Global Development Seminar Series for this invitation. It's a real pleasure. This is the first time I'm speaking at Cornell since I graduated in 2008. So really a great pleasure to be here. I know that the Perspectives in Global Development Seminar Series has brought to you speakers with lots of different backgrounds, and you've heard lots of different kinds of presentations. Today, I'll speak to you about some of the work that we've led at the Population Council, focusing on improving sexual and reproductive health and family planning of garment factory workers in South and East Asia. And instead of making this a very academic type presentation with lots of results and graphs and p-values, I'm going to be talking about tell you a story about how this happened, what this means in our broader mission-driven work around improving sexual and reproductive health and family planning globally, and how this work is continuing. And we'll talk about some of the opportunities and challenges that we faced as we did this work. So the outline of the presentation, many of you may or may not know the Population Council, so I'll spend a few minutes on who we are. I'll give you a little bit of an overview of the ready-made garment sectors in South and Southeast Asia. I'm sure you've heard a few things about the sectors, back from when we were talking about sweatshops to some famous, infamous disasters that have happened that have drawn attention to the sector. But these are really important sectors for economies of South and East Asia. So I'll talk a little bit about that. And then I'll go on to talk about the Population Council's history in working in sexual and reproductive health and family planning in these sectors, with a focus on two particular pieces of work. One, an evaluation that we did in Bangladesh, and the second one being a more comprehensive intervention that we worked on in Cambodia called Worker Health, both funded by the US government through the United States Agency for International Development. And I'll talk about some ways forward, some lessons learned, and what we're doing currently. So the Population Council is an international, not-for-profit, non-governmental research organization. We were established in 1952, and we're headquartered in New York City. We're a small niche research organization. We're about 500 staff globally. We have 12 offices currently in Africa, Asia, the Middle East, and Latin America. We've had offices in numerous countries all over the world, but we've also followed sort of this graduation model where once we feel like we've achieved our mission in some countries, we often graduate and move on, having built capacity of national research institutions. But we continue to conduct research in over 35 countries globally at the moment. We have three divisions, one for international programs where I'm based, one for social and behavioral science research, and we also have a center for biomedical research. One of the things that the council is known for is for having developed contraceptive technologies. Many of you may be familiar with the copper T IUD and the implant, Norplant, Mirena. These were developed at the Population Council and, as you know, are used widely globally. But the core of our research is also on social and behavioral science research. We do critical health and development issue research focused on sexual and reproductive health, family planning. We have a broad focus on adolescents and youth with a particular focus on girls. We also have what we call the Girl Center, which houses data sets from all over the world, and we conduct research on adolescent girls and young people. We also have a focus on gender equity and a renewed focus on climate change as we begin to understand the intersections between these issues all over the world. We are also known to have pioneered operations research and implementation science in reproductive health and family planning. And we have been a perennial partner for USAID over the last 4 decades all over the world in conducting operations research on these issues. Another great mission of the Population Council has been to build the capacity of developing country researchers and scientists all around the world. We've had fellowship programs all over the world, ranging from Vietnam to Egypt. We've incubated research centers all over the world as well. So that's sort of in a nutshell who we are. Today, I'll speak about the issue of garment factory workers in South and Southeast Asia. The risks that are faced in terms of health for these workers is well documented. However, there's been a significant lack of a concerted effort to bring together enabling policy in bringing access to information and services and an evidence approach of understanding what works in this sector to really understand how we can improve outcomes for this very big segment of many of the country's populations. I'll talk about each of the sectors in a second. So programs that have been designed to address these issues specifically have been limited, or they have not been as comprehensive. They've often focused on service delivery, but there has been a growing involvement of bilateral and multilateral donors and industry players. So when I say industry players, I'm talking about manufacturers and sourcing brands, big brands like H&M, Levi's. There is an increasing interest from brands and manufacturers as well to improve the health of workers because they see this as a way to increase productivity, and they see a return on investment for these kinds of investments in health. And the Population Council has been a partner in this work for the last decade or so, specifically in South and East Asia. So a little bit of background on the two garment sectors that I'll focus on today. Bangladesh and Cambodia. Bangladesh has the second largest garment sector in the world after China. It has over 4 million workers in 5,000 factories. As you can see, the percentage of female workers is about 65%. So it's a very feminized sector. And it delivers a revenue of around $34 billion. This was pre-pandemic numbers. These, I'm sure, have changed a little bit, but this was at the scale at which it was delivering, contributing towards the national GDP. The percentage of exports it accounts for is around 84% in Bangladesh. In Cambodia, the numbers in terms of the proportions are similar, but the workforce is significantly smaller, less than 1 million workers, 800,000 in about 800 factories, more feminized, 80% female, delivering about $8 billion to the economy and representing 71% of its exports. So in both countries, the garment sectors are extremely important. In fact, the most significant pillars of each of their economies. So the workers in the garment sector are extremely important for both of these countries. So understanding that and knowing, and the council has always had a focus on improving women's health, focused on reproductive health and family planning. So the targeted approach to looking at garment sectors that are heavily feminized was also an approach of efficient and effective programming, because this is a large sector that if we find an effective way to work in these sectors, the impacts are very significant. The return of investment is very high. We've done primarily formative, qualitative, and quantitative research in garment sectors in Bangladesh and Vietnam over a period of about 10 or 15 years between 1998 and 2012. This is when the sectors in these countries were beginning to gain some attention. But more recently, since 2013, we've received investments from USAID to examine various issues in this sector. The first one was the BSR Health, Her Health Program Intervention Evaluation, which I'll speak about in detail. And that led to a larger investment in Cambodia with multiple partners and a multi-million-dollar investment from USAID called Worker Health. And we're currently working to meet the garment factory worker needs in health in Egypt at the moment. For the historical work that we've done, in the interest of time, I'll mostly talk about sort of what has happened post the Rana Plaza disaster. Now, I don't know if many of you would be familiar with this. In 2013, there was a very significant disaster in Bangladesh where a factory building collapsed and over 1,000 workers died. and many more were injured. And that disaster really brought a lot of attention to occupational health and safety and compliance in this sector. But that also led to a broader focus on the health and well-being and rights of women workers, specifically in the garment sector. And that has increased investments in sexual and reproductive health and family planning, because women's overarching overall health is being seen as an issue of importance in these countries. So this has been an entry point for the Population Council, because we have been broadly interested in sexual and reproductive health and family planning for women globally, for low-income women in lower and middle-income countries. And this has been an entry point for us into this sector. So in 2013, the Population Council received a very large USAID cooperative agreement called Evidence, focused on strengthening family planning and reproductive health programming through implementation science, with a number of partners. And under this agreement, we were requested by USAID to engage with a group called the Business for Social Responsibility. It's an industry group that connects key industry players like brands and manufacturers with NGOs that work on improving health and advocacy for health for garment factory workers and other areas of manufacturing. So BSR has a very important program called Her Health. Her Health features both her project, I should say, and her project features both Her Health and Her Finance, that focuses on economic empowerment on the finance end and sexual and reproductive health on the Her Health end, given that the various geographies that they work in are heavily feminized in terms of their manufacturing sectors. So we worked with BSR to evaluate their Her Health intervention, focusing both on general health and sexual and reproductive health of workers. And this was, the Her Health program in Bangladesh was a fairly large program. It featured over 117 factories. It trained peer health educators, over 5,000 of them, and reached almost 200,000 workers. And if you look at the names of the brands, the participating buyers below, you will see lots of familiar names from the West in the United States as well. Abercrombie and Fitch, Nordstrom, British brands like Primark, Marks and Spencer. These are all names known to us, Levi's, for example. So these are participating buyers who source from these factories where this Her Project intervention worked. And Her Project focused on advocacy, on training peer health educators to help train workers on and provide information on sexual and reproductive health, family planning, and other aspects of their health to make better choices and decisions. And what we were tasked to do was to evaluate whether this was working, whether it was delivering positive outcomes. So we designed a quasi-experimental evaluation for this, featuring your traditional pre and post intervention design with controls, working in 8 factories for intervention, for control. We let the intervention run for about 18 months and conducted over 2,000 interviews at baseline and end line to do a difference in difference evaluation of the intervention. And we covered basic sociodemographics as you normally would in a survey or a study of this nature. But the key focus of these studies were around both health knowledge and attitudes, as well as on the utilization of services. So on knowledge, we looked at family planning, reproductive health, HIV and AIDS, STI, feminine hygiene, maternal health, nutrition. And we also looked at whether services were being utilized in family planning, STI and HIV prevention, treatment and care services, utilization of maternal health services, including antenatal care, delivery care, and postnatal care services. So the idea was that the intervention that Her Project through these implementers were implementing in the factories would increase knowledge and would also induce behavior change to deliver better outcomes on these very outcomes that I'm talking about. And what we found was that her health, through this rigorous evaluation, it was the first one of its kind done in the garment sector that had control groups and where we did a quasi-experimental evaluation. We did find that the Her Health intervention had positive impact on knowledge and behavior related to menstrual hygiene specifically. The training involved providing information about menstrual hygiene, using sanitary products, and we found both improvements in knowledge as well as behavior. We also found a positive impact on workers' knowledge of STIs and HIV and AIDS, as well as knowledge of recommended antenatal care and the use of contraception. And one of our most important findings was that it had a positive impact on the use of modern contraceptives. So we found that in factories where Her Health interventions were being conducted between baseline and end line, the increase in the use of modern contraceptives was higher than that of the increase or the change that we saw in intervention factories. And overall, we did some qualitative work as well with factory managers, and we found that factory managers and manufacturers were supportive of the intervention and valued healthy workers. Now, one thing I'd like to point out is that one of the biggest challenges in working in the garment sector is that, you know, when you work in the public sector, all you have to do is convince the government that this is important, and you gain sort of the trust from the community, and your work becomes a lot easier. In this sector, to work in garment factories, you have to get the buy-in from the manufacturers and the managers who run the factories, because they see any kind of intervention that's not, or any kind of activity that's not production to be an opportunity cost. So over the course of the work that we've done in both in Cambodia and Bangladesh, convincing and sort of pitching to factory managers has been one of the most important pieces of work we've done. So as we were doing this work, it gained traction at USAID in Washington, and the USAID mission in Cambodia had also begun to think about looking at designing a very comprehensive intervention that covers their entire garment sector. At the time in 2015, they had 700,000 workers and represented about $5 billion per year. It was a very significant sector for them. So the mission in Cambodia, the USAID mission in Cambodia, invited the Population Council and our partner, Marie Stopes International, which is a service delivery organization that focuses on reproductive health, family planning, to design a project and with an initial funding of almost $8 million, actually. The figure here of 3.8 was after some funding cuts, which is to be expected with USAID funding. And we were invited to design this project based on the knowledge that we had of working in other places like Bangladesh. And initially, this was the largest grant that USAID had made in the garment sector for health in the world. And we even had a chance to brand it, and we called it Worker Health. And it was a project that went beyond the kind of work that we did in Bangladesh, which was simply an evaluation of an intervention. This project featured not only health service delivery and access improvements that was led by Marie Stopes Cambodia, but it had a significant component on the enabling environment, working with policy and advocacy, so that we're not only focused on factories and workers in certain places, but that we could have systemic impacts on the entire sector, and working with all kinds of industry stakeholders, from the government to representatives from the worker side, to also to the on the end. Excuse me, I have some background noise coming from my neighbors. The other focus of this project, which is very significant, was on research. Typically, it's not common to have significant investments in research and advocacy, but USAID committed significant funding to ensure that we had a learning agenda that ensured evidence-based learning as we went on, to conformity research, to do evaluation research, and to generate evidence so that it can be used. while the project was going on. So we saw this as a living project, as we call it. Research that we conducted helped to understand barriers to access and problems associated with the sector, which led to the design of our interventions. And research to improve the processes and health services led to better policies. And we saw this in sort of this cycle informing one another. And this was a first of its kind project in the garment sector anywhere in the world. I'll talk briefly about what we did in the learning agenda. One of the things that we did want to change was that many interventions that had been implemented in the garment sectors all over the world had focused primarily on just implementing interventions. There really was not much in terms of learning about what happened, whether the interventions were impactful, whether they had challenges. There was no focus on documenting these interventions as well. But what we did with our learning agenda was to go throughout the whole research process. We first conducted formative research to inform our interventions. We assessed the needs of the garment sector by talking to workers themselves. We wanted to understand their health needs and how they sought health to design our interventions. We also did a comprehensive review of garment sector health programming in Cambodia to understand what was being done and what were the significant gaps that we needed to fill. And using these documents that we produced in the first year, we changed the status quo of how interventions were designed. We used our own research to design our interventions, placing a renewed emphasis on research and evidence. And I put this photograph on the slide here because we were among the first to invite all stakeholders to the table to present our findings and to say why we're designing programs in the way that we did. And this was to ensure that we get buy-in from all the stakeholders as we went through this process with them. And in this program, we had major brands join us. We had representatives from worker unions, from the manufacturers side. We had the government, we had donors, and we had NGOs like ourselves who were working in the sector. Another thing that sort of changed the status quo was that it was very rare for the different actors and stakeholders in the sector that were all working in the garment sector for various reasons to come to the same table. And one unique thing about the garment sector is that there are some competing interests. The government has an overarching interest to improve the economy of the country. The brands have an interest to gain productivity. The workers have interest in workers' rights. So they're competing interests, and we wanted to ensure that whatever we did, that we had agreement and consensus. So one of the things that we changed in the sector and how we worked was to bring all partners to the table. And what we did was we ended up bringing brands and manufacturers, research organizations all together. One thing that we did was also to study understudied topics in the sector. There had not been a rigorous study on the situation of garment sector worker health in Cambodia at all, and interventions were being designed without this information. So we conducted one of the first of its kind, surveying 1,000 workers in factories in Phnom Penh and Kandal, the two key provinces in Cambodia where most of the factories are based. We also struck up a partnership with H&M, which was also a unique thing. There had been no such partnerships before. We did this. H&M and the Population Council worked together on a study of housing and living conditions of garment factory workers. We went to the dwellings of 500 worker residences and looked at water, sanitation, hygiene, living conditions. In doing so, we partner with both public and private research institutions. So you see logos for the National Institute for Public Health, which is an arm of the Ministry of Health, which did one of our studies, and Anchor Research, a private institution for research who did another one of our studies. So building the capacity of both of these institutions as we did this, and working with H&M. The work with H&M was very interesting because H&M had a very clear strategy on improving worker residences. And we were able to help them out by designing a very rigorous study on worker living conditions. And in return, we got access to factories from H&M where we could pursue our service delivery interventions. So I see that I only have 10 minutes left, so I won't focus on the specific findings per se, except to note that we found that Cambodian factory workers have unique contraceptive needs, often driven by fertility intention. So contraceptive use before having their first child is very rare, and that's why short-term methods and traditional methods were very popular because they're easily reversible and they were able to discontinue to start pregnancy whenever they wanted to. On the living conditions study, we found very interesting findings. We did find that the living conditions of workers in the factories that we went to, or of the factories that we went to, were not bad. Actually, they had decent access to infrastructure and facilities, but they did face risks. Like if they were renting, they would face risks around being exploited by landlords, for example. If they were renting in dormitory style living close to factories, which meant cramped living conditions. This is pre-COVID, so this produced more risks now, but they had better access to water, sanitation, and hygiene. If they were owning their own homes, that means they lived further away, causing issues for commutes to work and things of that nature. All of these results were given to H&M, which helped them design their strategy. So I've talked a little bit about the H&M and the research institution partnerships. Another thing that we did in the work around policy was to conduct an analysis of stakeholders. I mentioned earlier that stakeholders working in this sector have unique and competing interests. And we did this stakeholder analysis so that this document could be for public consumption. So that anyone who wants to work in the garment sector to improve health and well-being could understand who the key players are, what their interests are, what their interest in workplace health is, as well as what their policy influence is, so that they can be best targeted. Another important thing that we did that had impact on the entire industry, as opposed to specific factories and workers, was to support a multi-sectoral and multi-partner process on developing guidelines for enterprise infirmaries. Every factory in Cambodia is required to have an infirmary or a clinic, but they were not guided by any kind of guidelines of what they needed to have. It was sometimes factories just for compliance would have a room with a medicine cabinet. But with the support of the Ministry of Labor and Vocational Training and the Ministry of Health and all of these partners, we developed guidelines. And this is now a law in Cambodia. So all factories are now required to have these minimum package of services, minimum number of beds, personnel, based on these guidelines. And because of this, this impacts the entire industry in Cambodia. And this has been an exemplary process that we've documented through this program. I mentioned to you that we brought diverse stakeholders to the table. One interesting fact about this photograph is that in a country with as significant of a garment sector as Cambodia, this was the first time that a representative from a brand sat together with a ministry representative at the same table at an event like this. So there were representatives from the Ministry of Labor and Vocational Training and H&M at this table, as well as USAID. And we facilitated that by trying to be a trusted broker between these different stakeholders. So I'll briefly just talk about the intervention that we did. This was done by Marie Stopes International. The intervention focused on communicating positive messages about family planning and reproductive health. We strengthened garment factory infirmaries by training personnel in those infirmaries to provide counseling and simple short-term services for family planning. We created a network of quality assured family planning providers by training them to provide short and long-term methods. and then created a referral network of these quality assured providers in certain geographies using digital technologies. We've actually mapped using GIS all of the pharmacies, clinics, and other service providers that were able to provide health services to garment factories in Phnom Penh and Kandal. We mapped factories and also residences, and we enabled and trained infirmary workers to provide referrals using this system. You know, all infirmary providers had tablets that could provide a referral if a woman wanted to get an IUD, for example, after a counseling session. This GIS-enabled app could point to the nearest place where they could get an IUD, produce a referral through a text message, and we could track that referral on whether that service was finally used. So we use the system to track all of these things. And so in terms of impact over the course of about 2.5 years that we worked on this project, almost 19,000 referrals were made for either for counseling or for voluntary family planning. Nearly 20,000 more than 20,000 voluntary family planning services were availed, 4,000 couple years of protection produced, and an estimated 11 maternal deaths averted, and nearly 5,700 unsafe abortions averted. These are results from our STOP's analysis of our impact. And the range of studies that we produced these recommendations around behavior change. We needed to be sure, if we want to work in factories, that we needed to be less intrusive to the work schedules. That's important both for workers as well as for manufacturing companies, and that it needed to be accessible to illiterate workers. Important to recognize cultural differences. There were lots of misconceptions around long-acting methods, as there are globally, around side effects, costs, biases regarding long-acting methods, and the recommendation was that we needed to focus on that. Recognizing that there is a very strong preference for short-term, short-acting methods among workers, and how to address that need while being sensitive to their preferences. We also produced some factory and provider focused recommendations. Importance of using colloquial language with patients, adding training methods for counseling, and improving the ability to counsel on a full range of contraceptive options without biases. Often you'll find that a provider may have a certain bias around a certain method, and that's what ends up getting prescribed. We talked about basic hygiene and sanitation from our study, and noted this is an important thing to be considered in the future, and really emphasizing the central role of the garment factory infirmary as the first point of contact where workers seek services, and which really drives the trajectory of how they seek services around family planning and reproductive health. So these are my last 2 slides. So we have about a minute left. One thing that we did from this project, lessons learned, is that it is very challenging to work in the garment sector, because you do have to work in a way that satisfies the worker side, the manufacturer side, the government side. But it can be done, and that's what we found out through the work that we did in Cambodia. We've documented this model, and we think that this can be replicated in other countries with significant garment sectors like Bangladesh, Vietnam, Myanmar, Egypt. We're doing something in Egypt right now. We transferred our technology, the GIS map of garment factories. The apps were transferred to national stakeholders, and we believe a version of it is being, at least was considered being used by the National Social Security Fund, or the idea of it has been used by the National Health Insurance. The infirmary guidelines that I spoke about is officially policy, so that was a major win for us. And in terms of knowledge products, now that they're about 5 years old, I think it's probably time for a refresh. But over the last 5 years, they would have been used by other partners who worked with us to improve their programming. And the garment sector continues to be economically a very important constituent in Cambodia. So this is important work. Due to travel restrictions over the COVID period, we have not been able to follow up about what has happened. But as travel has gradually opened up, I'm planning a visit to Cambodia very soon to see where the sector is at the moment. But I just recently returned from a visit to Egypt, where the Population Council has engaged with the garment sector, with USAID funding and with funding from the Dutch government. We're focusing on reproductive health and family planning of garment factory workers in both Port Said and Alexandria, both in these free investment zones, with work that's focused on peer educators, factory infirmaries, family planning counseling, private and public providers. As you can see, the type of work that we're doing is very similar. And this, we believe, is a model that can be replicated with lots of success, as well as multiplicative impact globally. So we strongly believe in this work. What we're doing now as travel opens up is to begin to engage with donors again, to show that this has a great deal of return on investment. There are major players in the donor world who are also interested in this. We found out in Egypt that the European donors are very interested in this sector. But one key thing that we learned, and this is the last point I'll make, is that, and the key realization is that this can only be successful and sustainable if we have buy-in from both governments that care for their economies through these sectors, as well as the manufacturers. So this can't be a donor-driven sector where interventions are always funded by donors. So we did a lot of engagement with key manufacturers and brands. So we engaged with Levi's and The Gap, H&M, with Primark, Marks and Spencer, to ensure that they understand that investments in the health of their workers, especially in women's health, if the sectors are feminized, if they make investments, it produces returns in less absenteeism, less unintended pregnancy, more productivity. And essentially, we needed to convince them that it improves their bottom line. And that's the pitch that we're continuing to make, so that the investments become more significant and it can be a sustainable line of work in the future. So I'll stop there, and I'm happy to answer questions about anything that you might have, processes, the research that we did, advocacy. Thank you so much.
Great. Any questions?
Hi, Ashish. I'm Shub Shuen. I'm a research associate at Status Quo Institute within Global Development, and glad to see the Population Council work here, because I worked in Population Council Southeast Asia office in Delhi long back before 2015. So I have like a series of questions, but I'll just keep three to be fair about the timing. So about the Bangladesh, I will just divide two questions for Bangladesh and one for Cambodia. So about the Bangladesh has a prehistoric kind of reputation of achieving the higher indicators about the family planning, the low fertility, the contraception use from longer historical time. So when you are talking about there is a positive change in the knowledge and practices about the family planning and other things. So what is the change? What is the delta in that? And also that will bring forward what really worked of that BSR, what really worked to bring those changes? What are the magic bullets that you saw during the evaluation? And my second question will be again very it's about your methodologies. So did you interview these women within the factory or in another setting? Because we did something very similar with Population Council in India. I was in India with the IOCL workers, and we are evaluating for World Bank, and we saw the difference in responses when we interviewed these workers within the factory setup, where the service providers are still there and the infrastructure is still there, and when we interviewed at their place of residence. So did you encounter those kind of issues? So do you want me to ask the Cambodia question, or?
Let's go with those. Yeah,
Okay.
let's go with those first. Good. You want to respond to those first, and then we'll.
Sure, I'll quickly respond. You're right that Bangladesh has been known to have great indicators both in maternal health and family planning. So I guess in terms of looking at what the delta, as you put it, we did see higher baseline numbers, but we saw improvements on top of those. Now I don't have the figures right in front of me, but I will. What I can do is I can provide links to the publications that we have. So the point is that even with higher baselines, we were able to realize gains in those baselines in contraceptive use, in use of feminine hygiene products, et cetera. So that is sort of additional awareness that was created. I think you talked about a magic bullet. There were so many things that I probably can't go into every one of them, but one very insightful finding was not only to provide information. So it's not enough just to provide information. Sometimes the information has to come together with a product. So one thing that happened was that in the training sessions with the BSR program, not only were women in the program informed about various aspects of feminine hygiene, they were actually given access to sanitary products as part of this program. So we saw increases in use of certain sanitary products when it's information paired with services. And whether services are subsidized, and that, I think that's a longer discussion, but often it's not enough just to have information. In terms of the question about interviews, whether they were done in factories or not, we were very sensitive to that. Obviously, when you do research, you want to make sure that there is confidentiality, that workers or participants don't feel that their participation in a research project would harm their prospects at a factory, for example. So we took good care in ensuring that interviews were done in private. The situational analysis was done in factory settings during lunchtime, in the absence of factory managers in the vicinity, done with an organization that had vast experience of conducting these type of research projects. And we trained them very specifically to address the issue that you've mentioned. The study on living conditions was done completely independent of factories. They were done in their homes. And we did not see a very significant, we didn't kind of put these two studies side by side to look at bias, but we believe that even the studies done in the factories were done with the utmost care taken on the issue that you just mentioned.
Great, thanks so much. I think Dr. Mubaya has a question.
Ashish, thanks for the wonderful presentation, for the excellent work that you're doing. I'll make my question very brief. So if you're thinking of expanding to other countries, could you comment on the role of, or lack thereof, of religion in the way that you go about with the program and its potential impact? Cambodia being predominantly Buddhist, and some of the countries that you're going into having more, Muslim population and Christian population, I would imagine that when you're talking about female sexual health, that has to be a factor in terms of both the design and impact of the programs. Could you comment on how you plan on addressing that?
Can I answer that one?
Sure, go for it.
Okay. Well, that's a very interesting question. And, one thing that that we've, come to learn with the work that we've done in Bangladesh is that despite Bangladesh being a predominantly Muslim country, there is significant openness to family planning and reproductive health. And that was sort of the previous comment around why Bangladesh has had really great numbers. So not all countries, purely just of how sort of the religion works, affects how difficult it is to work in those settings. The countries that I've mentioned, in Cambodia, we actually didn't pay very much attention to religion because we did not see it as a major factor. In Egypt, there are some considerations in terms of cultural conservatism, but I would say that they are contextual factors that we consider in designing the intervention, as opposed to considerations of deciding which countries to go into. You know, in a non-garment sector example I can provide is that we've done some work, I've personally done some work in the Philippines on adolescent sexual and reproductive health. Now, everybody in the Philippines who cares about adolescent health understands that adolescent sexual and reproductive health is an extremely important factor, but they need to work within certain conservative cultural and religious confines. So they find creative ways to work around that, even the ministries of health. So sometimes, you know, in our reports, we may not say sexual health, but we know what we're talking about. We know about the importance of contraception. We know about the importance of understanding, you know, adolescent reproductive health issues for young women. I think that's why some of this formative work is important. If you do the formative work right, you will understand what the cultural and religious nuances are, and it helps you design the intervention. But I wouldn't say that sort of religion comes in as a factor in us deciding where to go.
All right, thanks so much. And I think we have one last question online from Isha that kind of builds on your last comment about sort of in Cambodia, you mentioned recognizing cultural differences and targeting men as one of the worker-focused recommendations. Can you elaborate on that? I think that kind of speaks to what you were just saying, but in terms of especially, I think the men question, like how are you thinking about that aspect?
Well, I think men have always been an important consideration for all of our family planning and reproductive health programming globally. Sometimes they don't come out as strongly in the presentations that we make, because often we're talking about contraceptive methods that are being used by women. But couples communication, for example, raising awareness of men on contraceptive methods, ensuring that decisions are you know, taken in a well-informed manner. In some contexts, women may have issues with talking to husbands about certain methods. So, you know, we both do sort of the formative work to understand what the context requires. But in all of the work that we do, we focus on men as well. Now, all of our interviews focused on, I mean, they were interviews of women. I have to be clear that we did not interview men in these projects because the interventions were targeted specifically to women. But in all of the work that the peer health educators do, or in the intervention around, you know, counseling, for example, the men are involved, and the men do come in with their spouses. So men are maybe not the primary focus of these interventions, but they are there, and they are an important part of the work that we do. Now, in the two studies that I presented, we didn't do studies with men, but of course we interview men and understand their preferences and things of that nature in the broad family planning and reproductive health work we do elsewhere. So they're very key. And they're also very key. Last point, Sarah, sorry. They're also very key in the work that we do in gender-based violence, which is another big portfolio that we have. Thanks.
Awesome. Well, thank you so much for coming and sharing some really both rigorous but also exciting and creative efforts. And we really enjoyed your talk. Thanks so much for taking the time with us.
Thank you so much. Great to be with you all.
Very well.